Real people, inspiring stories, living legends. Award-winning talk show. Trevor Blackman Now.
Right then, time now to look at health inequalities in the Black community. Two councils teamed up this year in a bid to address health inequalities faced by Black people here in the UK. Lewisham Council and Birmingham City Council published a report featuring 39 ways to tackle the impact of disadvantage and discrimination. The report proposed increasing the uptake of health checks among Black people and supporting migrant women with no access to public funds. Critical action, they said, is needed to address vast and persistent ethnic inequalities in healthcare right here in the UK. Well, joining me now to talk through some of those findings and to offer some insight into what the NHS and our clinical commissioning groups are doing up and down the country to address some of the largest inequalities found, especially in mental health and maternity care, is our resident doctor and psychiatrist, Dr. Seshni, who joins me now. How are you?
I'm great, thanks, Trevor, and lovely to be on your show as always, and to talk about something that's so important, to both of us.
Absolutely.
And I mean, how much time do you have? Because this is a huge topic, it affects so many people in the BAME communities.
Absolutely. Well, we're going to take as much time as we possibly can. So I want you to talk to some of those inequalities that Black and brown communities are facing here in the UK. Talk to us about some of your findings.
Yes, I mean, it's no surprise that the findings of the report, the one you've mentioned, as well as the NHS Race and Health Observatory, they published a report in February 2022. And according to NAVKI, the person who signed off the report, he said not to take action should not be an excuse. So we do need to take action. And it's something that we know has been there pre-COVID, post-COVID. We know that in the BAME communities, the Black, Asian and ethnic minority groups, that they've been disadvantaged. So it's not something that's new. It's been ongoing. But we are hoping, as you've said, with the proposals put forward in terms of putting campaigns, educating communities, especially our communities, we need to think about how we can actually get people in our communities to take up in medical treatment, which is really important for every single person.
Absolutely, and I think you as always, you're straight in there, particularly about access. It's about having primary care, clinical care accessible. And it's also about doing things prior so people don't end up in hospitals and seeking GP support. If we put a lot of some of the things I think we're going to talk about in places that are easy accessible, like schools or community centres, when we talk about diabetes, when we also talk about those who may be experiencing some kind of psychotic episodes as well and I don't understand this clinically, so I'm sure you're going to explain it to me, but there are signs which say, okay, you're on the verge of, if we can address it prior, it might stop people from being sectioned, etc. And particularly in the Black and brown community where they're overrepresented.
Yeah, you don't need me, because exactly when I was preparing for this, I've written down about education in communities, in schools, in mental health institutions, in the NHS, where people need to be educated about the different conditions, how to access treatment. Prevention is better than cure, we always say. And also in terms of, like, you spoke about diabetes, high blood pressure. From the findings of the inequality, the reports that were prepared, what they found is that in these communities, people were not accessing healthcare, or even if they were accessing healthcare, they were scared to even access because they felt that there was racism towards them. They felt there was a delay in treatment. You've heard the podcast Archetypes from Meghan Markle, and she spoke about Serena Williams being medical gaslighted. So this is a real problem that people in the BAME communities are experiencing. And as a result of it, because they're not seeking care, as you've said, then we see an increase in the number of physical health and mental health conditions, and to a state where people are experiencing a psychotic episode, as you've just said, and ending up in hospital being sectioned. So it's about educating these communities, and it's about telling them that it's okay, that they need to ask for help and they need to access the help. Yes, there has been a history of race inequality. And I remember when we were doing COVID and with the COVID vaccines, they had campaigns, to increase the amount of uptake in the BAME communities because they did not want to do the vaccine. We spoke about your mum. We spoke about so many other people. And because of the mistrust and because what has gone on, because of the political situation, it affects inevitably the socioeconomic and also the uptake of the BAME community in terms of seeking help for medical and mental health care.
Do you think lessons have been learned, taking us back as you just had to our conversations, and we talked about the hesitancy in relation to taking up COVID, as you said, the historic experiences of racism have been dealt with by professionals in a very off-putting way. I mean, in the report that you cited, Black patients were more likely, when in terms of mental health, to be restrained, not listened to. In maternity services, research found that evidence of negative interactions and stereotyping from professionals to patients. Have lessons been learned? Are you seeing that in the practices where you work? Because I have to say, for some of my friends, they're not seeing any of those changes that should have now been enacted.
I think it's always a process, isn't it? And I think the fact that the knowledge is out there, the information is out there, it cannot be ignored. And I'm hoping that lessons have been learned. I'll just take, for example, our GP practice. When we go to the practice, I'm seeing a lot of people going there. You have to go early hours of the morning, get your appointment, about 8 o'clock. And then get in and get seen. So I think when I see the way the process is happening in terms of that, I feel that there is no inequality, that it will be up to the person to then seek the help. But once you get through the doors, then obviously that's where the difficulty lies. So I'm hoping that what came out of the report is that they said education, so educating people, educating health professionals, educating communities about the different mental health illnesses, physical health illnesses, how to manage the inequalities. So I do feel that somehow that we have moved on. Rome wasn't built in one day, and I don't think it's something that's going to be tackled overnight, but I do feel that somehow that people have learned lessons, and I'm hoping, working in the healthcare, I'm hoping that people can access healthcare equally, amongst all race groups. There should be no discrimination.
So what are the conversations happening that you've been privy to in relation to these reports? And there were previous reports today. Let's just stay with where we are now. What are the conversations to make that change take place quicker? I know you said Rome wasn't built in a day. It takes time. But, historically, it's because in many ways, medicine has been aimed at or research based on in terms of white Caucasian, and therefore services have been aligned looking at that type of person, that blood type, that physique, that what changes are being made to look at people holistically and saying there are differences in terms of how we can work with and treat different ethnic minorities?
Well, I think it's not being sort of segregated in terms of that. I think overall, what we are seeing in terms of providing holistic treatment, services are talking to the stakeholders. So this is where it boils down to speaking to the stakeholders, who then obviously provide the care, safe and effective care to everyone equally. So I think this is where it's coming from, where it's stemming from. So it's educating the stakeholders that obviously there are different groups of people. We do need to target certain communities, and that is why we see different campaigns going on. You see campaigns about female health, female reproductive health. You see about male, prostate cancer awareness, diabetes, high blood pressure, and stroke. You're seeing that different communities are being targeted. So I think on the ground, this is what we are seeing, but the conversations that we're privy to, obviously the stakeholders and the services, so it then feeds to the services which we provide, so for example, community mental health services are then obviously it's filtering down, explaining that we need to provide equal care. From the report that I cited, interestingly, the mental health care amongst the bed community was actually poor, and also the IAP, the intensive access to psychological therapies, there was a lower referral rate for BAME communities. And also with social workers, they felt that children from BAME communities were more likely to be referred than from the Caucasians. So there's a lot of this information is out there, Trevor. So people need to act on it. And this is where the services are changing. They're now looking at how referrals are being made, how a referral is made. For example, if someone comes to the IAP, or educating people that they need to, from GP services, they need to then refer to mental health services. And you spoke about perinatal services as well. So hopefully, yes, things are moving forward.
And is that moving forward because services are now being co-produced with residents, with communities at the table to say, because of my experience, you need to hear this, and maybe that is now going to help you look at how you can redesign, and I want to be with you as you redesign those services for the community? Is that now taking place more, that co-design element?
Yes, exactly. You read my mind, because that's what I was going to say earlier on, is that because it's in the open, it's knowledge that is known. We heard Dr. Shola, when the reports came out, she was very vocal about it. So the more people we have talking about it, not just at her level, but at the primary care level, and then secondary and tertiary care, then and also being part of that process in providing that care or having a say, I think this is where things are changing. And also, you must know that more BAME community are being educated. We have a large number of health professionals in the BAME community, and because of this information, it's not something that can be ignored. And I do feel, even working in the private healthcare when I worked, these conversations people were being courageous and opening up and talking about it and saying, but this is access to healthcare. It's a human right for every single person. United Nations, we have the UN, we have all these other organizations, World Health Organization. So, and we saw with COVID, access to the right healthcare was a right for every single person, and there should be no inequality. But I think it has to change from a professional level as well as a community level. I think on the one hand, we have two different views. The professional level, where obviously the problem sometimes happens, where there's a delay in healthcare, but also on a personal level, where people are not trusting the services. They're delaying in asking for help. They're delaying in going and getting that referral because of historical mistrust and inequality. So I think it's a lot to tackle, and it's something which is a process.
Follow Trevor now on Instagram @official TBN Show.